Yes, thank you for the kind introduction. I'm Anna Walstra, but it's a Dutch name, so it's complicated. I will talk to you about combined protocols for the big three. We all know the big three, the three major smoking-induced diseases, and expected to cause most deaths by 2050. All three of them have imaging biomarkers that can be found in an early stage and can enable early detection. And of course, you want to include this in one low-dose chest CT to measure them all with one acquisition. But of course, the CT protocol parameters are mostly optimized for the three biomarkers separately. If you want to do this with a one-run non-gated low-dose chest CT, this can cause issues because we have to change the specific parameters. The aim is to do this in one acquisition with a high pitch, non-gated, but keep the specific reconstructions for the three imaging biomarkers, or more if you want specific kernels of more kernels to do your evaluation. But including this in the one acquisition can cause concerns on the quality, reproducibility, and robustness of the scans, and the effect this has on the image quality. And of course, this affects the accuracy and precision of the biomarker quantification for each of the three biomarkers. And I'll go through all of them now. So first of all, lung nodule measurements. This is, of course, the base where we make the protocol from usually, because it's built from a lung cancer screening protocol. But still, because we do the high pitch scanning, or that's the aim, it can affect the accuracy of the nodule measurements, because the volume coverage speed of not all CTs are good enough to provide high enough image quality. The image quality goes down, there's more noise, so this causes higher errors in the lung nodule assessment. And the dual source CT systems have the ability to scan in this higher pitch mode, causing better or providing a better possibility for this one acquisition. And the research has shown that high pitch mode gives comparable accuracy to the non-high pitch mode. However, the accuracy does decrease for the smaller nodules if we focus on the dual source CT specifically, and even also on the multi-detector CT, when you go from the pitch of 1 to 1.5, this can cause errors in ground glass nodules size measurements. So you always have to be aware of the effect your image protocol and your CT system has on your nodule measurements, and know what you're measuring is accurate. Then for the calcium score, usually we use the Agatston score, and the specific risk categories gives you an indication of the cardiovascular disease risk. And the first studies have shown that if you include calcium scoring in your reporting of lung cancer screening, it has shown an increase in statin prescription. So it does have an effect in the clinical management. If we look at the calcium score distribution in lung cancer screening populations for the Canadian lung cancer screening pilot, we've seen a calcium presence of around 83%. And we compare this to the Nelson study, this had nearly 79%, with both around a severe calcium score of around 30% of participants. And if we compare this to the general population, if we use the MESA study, we see a calcium presence of around 50%. But if we compare specifically the white male group, which is most comparable to the Nelson group, we see already a higher percentage of around 70%. And the higher calcium scores, which was here defined as about 300, was a lot lower. So we can see in the lung cancer screening population that there is a higher calcium presence, but specifically in the higher severe calcium score group. But you have to be aware when you make the comparisons, the effect of the male-female ratio, because we see in the Nelson, this is all males. And the Canadian pilot is around 50-50. But also the age in the Canadian pilot is much higher. On average, it's 66 compared to 58 in the Nelson study. This all has an effect on the values you're seeing. If we then look at the current for the long run study, and we looked at the calcium score of the whole baseline cohort, so this is nearly 12,000 participants, we see here a calcium presence of 86%, which is most similar to the Canadian pilot, and also in the male-female ratio and age, these are approximately similar. And 1 out of 3 participants is in the severe group, so this is also similar, even a bit higher to the Canadian and the Nelson group. And 14% is at low risk of cardiovascular disease with a calcium score of 0. This would exempt them from preventive medication, according to the current guidelines. And here, when we look specifically at the age groups, we can see this effect of age on the calcium score. With increasing age, we see increasing calcium scores, and also the difference between male, female, we see clearly the higher calcium scores in the male group. But of course, if we want to perform calcium score measurements in lung cancer screening, this can cause errors because we can't do ECG gating, so we use a non-gated scan and low dose, and not all CT systems can perform these measurements accurately. Studies have shown that motion artifacts occur, lower reproducibility, and this can cause cardiovascular disease misclassifications. And overall, the dual source CT, because we have the ability of the high pitch mode, it comes closest to the EBT with the best temporal resolution. In the For the Long Run study, we have also investigated the reproducibility, comparing the baseline scan to the 3-month follow-up, because we don't expect any difference in the calcium score here. And we see overall around 93% has a similar classification between baseline and the 3-month follow-up. So this overall has shown consistent calcium scoring using this one run acquisition, non-gated with the dual source CT. When we focus on COPD at this time, there's no recommendation yet to actually include screening for asymptomatic individuals. Only active case finding is now included in the guidelines. And also the US Preventive Task Force said there's no net benefit yet to screen for COPD, but this was based on questionnaires and spirometry. If we focus specifically on emphysema, there's also no guideline that includes this yet to include it for screening for asymptomatic individuals. However, we can include it in the current pilots to also show if there is any net benefit and show if there is potential to include this and measure this accurately with one run low-dose chest CT. Recent research has focused on deep learning-based kernel adaptation. So this showed improved emphysema quantification specifically for the low-dose chest CTs to predict long-term mortality outcomes. And another is automatic quantification. Methods. We compared LAA, this low attenuation area analysis, versus LA cluster analysis. Because of course, when we do this one acquisition, emphysema is mostly affected by the noise of the low-dose scanning in the high-pitch mode. But when we look at this comparison between LAA and LA cluster analysis, we did this on the Nelson protocol. So this was not done in high-pitch mode, but low-pitch, but still low-dose, and used for general lung cancer screening. We see that the LAA analysis is much more affected by the noise of the low-dose CTs. And LA cluster analysis shows a lot of promise. And in the future, we will also do this analysis in the For the Long Run data to see the effect of this high-pitch acquisition. So overall, we have this possibility to include the big 3 in one protocol. However, we need the validation to know that what you're measuring is accurate, because it's not feasible on every CT system that's available. We need to focus on AI performance because workload is already an issue, so we cannot assume radiologists can include this in their screening workflow. And including this, specifically emphysema, we can focus on the benefits of early detection and treatment of emphysema, because the evidence is, for this moment, it's still lacking. So we can, when we perform this for the long-run trial, future results will also show the feasibility and the best implementation strategies. Thank you for your attention.
Are there any burning questions? And I have burning questions. I think the presentation was spectacular, and what the work you guys have done is remarkable. Okay, so there's a couple of things. Emphysema, no recommendations. You got to realize that there's no recommendations because there's no data. And so that's an opportunity to produce data. The next thing is that you kind of mentioned a couple different times, is the inspiratory effort, the technical component to the acquisition is a really big deal. And Sean might comment on it on his presentation coming up. We could potentially, from this group, come up with some standards for coaching and for breath hold and all this other stuff, because right now it's the Wild West. And as you cross between nodules to density to calcium, it actually becomes a very big deal. And so this is something simple and doesn't cost a whole lot. If we could address this, we will get much tighter quality control. And then the final thing, real quickly, because there's a lot that you unpacked, is the idea that, you know, there's some parameters that might be affected by pitch and this, that, and the other thing that could really affect management. And we should kind of figure out if there's something that triggers a study that's questionable in a management sensitive area. We should have some kind of safety valve that says, you know, recommend follow-up diagnostic, whatever should be done, because there's a lot of mistakes that occur that don't matter, but there's a lot of mistakes that when they occur, could really matter. And we should start parsing that for our colleagues in a thoughtful way.
I have a question. Or was it just a commentary?
It was a diatribe.
I just want to agree with you and say that it affects everything. The volume measurement is affected by respiration. So if you want to look at volume change over time of a nodule, it's affected by the same thing. So the standardization is key.
I have a question. There was one of your slides said something about not recommended to look for emphysema. Did one of your slides say that?
Yes, you quoted the U.S. Preventive Services Task Force.
Yeah, it was, I think it said that it's not yet included to look for, it's not in the guidelines, it's not, how do you say it? It's not promoted to look for emphysema in asymptomatic individuals.
Yeah.
For screening purposes.
I'm trying to, I just, every time I see, and I've seen that written before, recommended not to, how do you not look for something when you're looking at a scan?
No, but it's not in general looking at a scan, of course, but it's not promoted to perform scans for the early detection of emphysema, specifically in asymptomatic individuals.
Because the way that slide read, it was like you should kind of somehow or other put blinders on and not look for the emphysema. And if you see it, how do you not report it? It's
especially when it's highly correlated with lung cancer.
It was one of the slides you had. It said about emphysema, but anyway, let's leave that.
I would also like to comment on the COPD topic. So there seems to be a discrepancy between the pulmonology description and definition of COPD, emphysema, and what we see in CT. So on the one side, clinically, most patients have a chronic obstructive lung disease, So we see it in spirometry, we see it in body plethysmography, and not so much emphysema. And we have one publication at least where body plethysmography measurements were compared with CT, and there seems not to be a correlation. So I'm not sure what we are measuring with the lung function tests and what you are seeing in CT regarding emphysema. I just want to mention it, and perhaps we should prospectively look at lung function testing and CT scoring regarding emphysema at least. And the other question is probably not doable. In chronic obstructive lung disease, we have also an inflammation of the bronchi. And this usually is not looked at in CTs, even in the standard CTs.
Updates on Rubinska.
Bronchiectasis, yes, but the inflammation of the wall.
Okay, so this is a very key point. I'm sure we'll come back to it, but I think we have to move on.